Hi, this is Subhawong, Assistant Professor of Radiology here at University of Miami. I'm just going to be giving a brief introduction on an approach to looking at elbow radiographs when you're in the ER. So just first off, these are some of the techniques that we use to acquire our AP views of the elbow and the frontal projection, and then a lateral view of the elbow, which is obtained with the elbow flexed at 90 degrees. Just going over some of the basic anatomy here. This is the medial aspect of the arm. So this would be the patient's left arm as if you were looking at them, facing them. This is the humerus ulna radius. Here we have the medial epicondyle. This is the sublime tubercle of the proximal ulna. This is the ulnohumeral joint. The radial tuberosity is here. So this is the attachment of the biceps tendon. The neck of the radius is inferior to the radial head, which is here. This is what I refer to as the radiocapitellar joint, with the radial articular surface here and the capitellum off of the humerus here. The lateral humeral epicondyle is here, and then here at the lateral epicondyle you have your attachments for the common extensor tendons. On the medial side you have attachments for the common flexor tendons. On the lateral projection, this is the supracondylar ridge. This is the olecranon fossa back here. Over the olecranon fossa you normally have fat, and in a normal elbow you won't be able to see displacement of that fat pad, but when there's a joint effusion, that posterior fat pad will get elevated, and that's an important sign of pathology, which we'll review later. Continuing around, you have the trochlear notch of the ulna, radial head here. This little piece of bone is the cornoid process off the ulna, and then again the radial head articulates with the capitellum, which you can see in profile here. So some of the basic structures we check for on a radiograph of the adult elbow: we look at the bony alignment. Again, we look at the presence or how conspicuous the fat pads are. Check the cortex of the bone very carefully for any cortical breaks or step-offs, and then evaluate the soft tissues. So in the lateral view of the radiograph, all the joints should line up. So the radiocapitellar line should be horizontal. The radius should always line up with the capitellum. And then the anterior humeral line should pass through the middle third of the capitellum. This is really more important in children when subtle supracondylar fractures can be picked up based on the capitellum being behind that anterior humeral line. The next structure we check is the fat pads. So the presence of an anterior fat pad is normal, but the presence of a posterior fat pad indicates a joint effusion. And if trauma, one should assume the presence of a radial head fracture. So as an example, this is a sagittal CT scan just showing these hypodense fat pads. Elevated here is the anterior fat pad, here's the posterior fat pad. You can see there's an underlying joint effusion that's pushing and displacing that posterior fat pad out of the olecranon fossa where it normally sits. On a lateral radiograph would be obscured by the surrounding bony contour. Again, this is on bone windows, a CT scan just showing the presence of that radial head fracture, which resulted in the effusion and displacement of the fat pads. The bone cortex should always be smooth, so this is something to check at the radial head and neck, at the cornoid process, and in the olecranon, because subtle non-displaced fractures can occur in these locations and be difficult to pick up if you're not keyed into them. So we'll first talk about radial head fractures. These are the most common fractures that we see in the elbow in adults. They're often very subtle, and again, if there's a history of trauma and there's an elbow effusion, you should probably assume that there's a non-displaced radial head fracture present. So as an example, in this lateral radiograph we see more displacement of the anterior fat pad than we would typically see. We don't see the posterior fat pad very well in this projection, but if you look very carefully at the radial head, you see this sharp kind of angulation at the head neck junction, and again that's shown here, and that little cortical step-off is indicative of a non-displaced radial head fracture. There's a classification for these fractures, the Mason classification, and we'll go over these in detail here. So the type 1 Mason fracture is just a non-displaced radial head fracture, so there's no articular step-off. These do very well with conservative treatment. The type 2 Mason fracture is a single fracture fragment that may or may not need to go to surgery for fixation. There's a general rule, which is the rule of 3, so if there's less than 3 millimeters of articular step-off, or if the fracture involves less than 1/3 of the articular surface, or if there's less than 30% annulation of the fracture, those are more amenable to conservative management. If there's greater than 3 millimeters of step-off, for instance, though, the patient may need to have open reduction internal fixation. The Mason type 3 fracture is comminuted and displaced, and this type of fracture usually requires surgical intervention. And then with a type 4 fracture, that's essentially a Mason type 3 fracture, which occurs with a elbow dislocation. So just as an example, this was a Mason type 2 fracture. This is the initial radiograph, and then several months later, you can see there's some residual articular step-off deformity, but there's not much in the way of radiocapitellar osteoarthritis, and this patient had a good functional outcome. This is another example of a subtle fracture. So you can see that on the initial frontal view and lateral view of the radiograph, the major abnormality that's obvious is this posterior fat pad, which should not be visible. Its presence, again, is suggestive of a non-displaced fracture, and when you zoom in on the radial head, you see this non-displaced fracture. So this would be a Mason type 1 fracture. Another example of a Mason type 2 fracture with a non-displaced fracture through the radial head. After several months of healing, you can see there's a residual step-off, similar to that case we saw before, but again, good functional outcome for this patient. This is an example of an elbow dislocation. So we're going to be talking a little bit about these. Usually, this is after reduction. Here's the fracture fragment from the radial head after reduction. So usually dislocations occur posteriorly or posterolaterally, and the dislocation is described in respect to or how the olecranon is positioned relative to the humerus. Up to 50% of these dislocations are simple, meaning there's really no associated major fracture, and it's a primarily soft tissue injury. If the coronoid tip is fractured greater than 50% of its height, that's an unstable fracture. And the thing to be aware of with these dislocations is their concomitant injuries. So radial head fractures occur frequently with these. There's also high incidence of multiligamentous injury involving the elbow. The terrible triad has been described as an MCL tear, or ulnar collateral ligament tear, radial head fracture, and coronoid process fracture. This is another example of a elbow dislocation. You can see it occurs, the olecranon is dislocated posteriorly and laterally relative to the humerus. This is a simple dislocation. There's no associated fracture fragments. Not all elbow dislocations are posterolateral, though. This is an example of a medial dislocation where the ulna and radius have dislocated medial to the ulnar aspect here of the humerus. You can see an associated fracture fragment here. This was, on other views, was shown to be coming off of the lateral humeral condyle. This is an example of sequelae that occur after previous dislocations. So we typically see these areas of heterotopic ossification in the expected regions of the collateral ligaments because those collateral ligaments were torn at the time of dislocation. You can see in this lateral projection that heterotopic ossification has formed around the anterior capsule and the brachialis muscle. Those structures are usually injured in posterior dislocations. There's probably a small coronoid fracture fragment here. Another type of fracture that we see commonly here at Jackson is the olecranon fracture. This generally occurs after direct blow to the elbow or fall on an outstretched hand with the elbow flexed. The triceps exerts an unopposed pull on the displaced fragment posteriorly. So we'll see that in this example where you have a vertically oriented fracture through the olecranon. There's displacement and distraction of the fracture fragments due to the unopposed pull of the triceps tendon, which inserts here at the posterior aspect of the olecranon. Also associated in this elbow injury was a radial head fracture. This is post-reduction and internal fixation of that olecranon fracture. So they used plates and screws to reduce the fracture fragments. Another type of fracture that we see are distal humeral fractures. So in this example, we have a fracture through the medial humeral condyle, and there's disruption of the articular surface. There's an anteromedial fragment that we see here that's completely displaced. And on the lateral view, again, you see there's no dislocation, but the fracture is involving the medial aspect of the distal humerus. There are different classifications for these distal humerus fractures. This is from the AO classification, and there's a nice website where they go through all the different fracture types and the different ways these can be managed. It's important to note on this classification scheme that what's being described is the relation of the articular surface to the rest of the shaft. So in this case, we see that the lateral column is intact. The articular surface of the capitellum is connected to the underlying column of the humerus, but the medial sided articular surface for the ulna is completely disrupted. This is an example of what happened after that fracture was fixed. So the distal humeral fracture, the medial column fracture, was fixed with plates and screws, and then some of the articular fragments were also fixed with these interfragmentary screws. The olecranon, you'll notice this tension banding fixation through the olecranon. There was not an original olecranon fracture, so this was a surgically created defect or osteotomy that was used to gain exposure to the elbow joint, and eventually this was fixed with the tension banding. One of the complications in this procedure for open reductions is that you can have non-union of the proximal or of the olecranon, and eventually in this case this had to be revised to plate and screw fixation after there was a non-union through the olecranon osteotomy. Next type of fracture we're going to be briefly discussing is a capitellum fracture. So in this example we have a lateral view of the radiograph. Elevation of the posterior fat pad indicates there's a joint of fusion. We see a bone fragment here floating in the anterior joint, and at first glance it may not be obvious where the donor site for that bone fragment is, but in this case you can see if you look at the radial articular surface there's a missing piece of bone on the corresponding humeral side, which is where the capitellum should be. So this is the displaced capitellar fragment. So capitellum fractures occur in the coronal plane. They're relatively rare fractures in the adult population, less than 1% of elbow fractures. Here's an example of a radial head fracture, but also a corresponding capitellar fracture. In this case, this is just a shear injury of the capitellum with a little bit of subchondral bone attached. This is known as a Kocher-Lorenz fracture. There is a different classification for these capitellar fractures called the Bryan and Mori classification, if you want to read about that for more detail. Another example of a capitellar fracture, you see this large displaced capitellar fragment here in the anterior joint. This was reduced and fixed with these threaded screws. And then just to close briefly, we wanted to review a set of eponymous forearm fractures just because they come up frequently, perhaps in a board setting. You may hear us refer to them for different injuries. They do occur in the proximal forearm. This is a proximal ulna fracture with an associated disruption of the proximal radio-ulnar joint. This is known as a Monteggia fracture. The Essex Lopresti fracture occurs when there's a radial head fracture that also involves disruption of the distal radio-ulnar ligament. So when you see widening of the distal radio-ulnar joint concomitant with a radial head fracture, that's an Essex Lopresti injury. And then the Galeazzi fracture is a distal third radial shaft fracture which occurs with disruption of the distal radio-ulnar joint. So those are just three of the eponymous forearm fractures which we commonly encounter. Finally, not every pathology in the elbow is a fracture, so here are some examples of different types of injuries or pathology you might see in where there's no underlying fracture. This is just a case of severe soft tissue swelling over the olecranon. The bursa behind the olecranon is called the olecranon bursa appropriately, and sometimes that can get inflamed or infected, and that's usually what is going on when you see a lot of posterior elbow swelling. This is an example of a supracondylar spur. Basically, it's just a normal variant seen in a small minority of patients, but the clinical relevance is that the median nerve can pass through this area and get trapped beneath the spur or beneath the ligament that extends off of the spur, known as the ligament of Struthers, and you can get a median neuropathy in that location due to compression. I said before that whenever there was a joint effusion and there was no obvious discernible fracture, you should be suspicious of a radial head fracture. There are other pathologies and entities that can cause elbow joint effusions. One of them is rheumatoid arthritis, or in this case with this patient was hemophilic, so he had a hemarthrosis in his elbow joint, and that obviously results in displacement of the fat pads due to the joint distension. Finally, calcific tendonitis can occur around the elbow tendons. We don't see it as commonly here as we do in places like the shoulder or adjacent to the greater trochanter in the femur, but this is the attachment for the common flexor tendon. You see these deposits of hydroxyapatite, calcium consistent with calcific tendonitis. So I hope this has been a helpful kind of brief introduction to elbow radiographs. Again, you should search carefully for subtle fractures, particularly in the radial head, coronoid tip, and capitellum. If there's a posterior fat pad present with a history of trauma, you should assume there's a radial head fracture if you don't see any other fractures. And knowing the injury patterns can help direct your search to pick up subtle pathology. Thank you.